had sepsis from UTI?
Yeah, I had UTI that went into a kidney infection.
Okay.
And then it just kept going.
Okay.
By the time I went to the hospital.
You had sepsis?
Yeah.
Okay. Oh gosh, Gina.
Good times.
So what were some of your symptoms?
I was in the hospital for 4 days. Huh?
What were some of the symptoms?
I had a really, really high fever, and
okay.
I couldn't get it down even with medication.
Okay.
Obviously, I had really bad flank pain.
Okay.
But I wasn't putting out a lot of urine either.
Okay. Okay.
And my blood pressure was really low that they wouldn't even let me out of the bed.
Okay. Good. So probably had some septic shock going along with that. That's just a septic shock. Okay, good. And what were they, Gina, what were they doing to treat you?
Oh, they were pumping me with fluids.
Okay, they were pumping you with fluids. Good. What else were they doing? Did they give you antibiotics? Yes. Okay. Okay. Good, good. But you bring up but that's a really great example. So a urinary tract infection is a common source of sepsis. Okay, so very good. Who else out there has cared for a patient with sepsis? And what did they look like, Pauline? With what? Oh, cellulitis. Good. So tell me more. How did that develop into sepsis? How did you know? Okay. 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 Getting better. Good. What were there any lab values or anything that you looked at? What were you noticing? What was abnormal? Okay. What were they? High or low? Low. Okay, good. What else was abnormal? What was it? His liver. Okay. Anything specific that made you concerned for sepsis? What? What was that? High. Good. Good. Excellent. Very good. Good. So we have a cellulitis. So we have an integumentary system, right? We have a urinary tract infection. Anybody else out there with sepsis? Not personally.
Pneumonia. And both in Charlotte and Waterbury, I noticed that there's a real pattern of patients who have pneumonia, UTIs, and sepsis. Mm-hmm. So I don't know, and some of them will have pressure wounds too. So it's like, good. I don't know where the sepsis may be.
Good. Yes, Tom.
Yeah, I heard it's complicated though. Like, did you just want sepsis by itself?
Well, what do you mean? Where are you going with me?
Like, because he has UTI, anemia, NSTEMI, HIV. This is the notes on one of my patients for a clue. Mm-hmm. And let's see, his white blood cell count is low.
Okay.
Actually, his red blood cell count is low. Mm-hmm. They found like blood in his urine, so he's bleeding from the inside.
Okay.
Hematocrit low, HTV low.
So one thing I want to stop you for a second now. Yes, Sarah. Perfect. Very good. Excellent. Very good. So Sarah, I want to go back to Nam for a second. So Nam's patient brought up one important fact about sepsis. What was in Nam's patient's history that made him at risk for developing sepsis? HIV. Very good. So he's immunocompromised. We're going to talk about risk factors in a second. And Sarah, what did you just say?
My patient had a positive urine culture and positive blood culture.
Perfect. Very good. So whenever we're concerned about a patient having sepsis, we're also going to make sure that we get blood cultures, right? And what is an important thing to know about when you get blood cultures? Excellent. You do not want to get blood cultures after you get the antibiotics, because then you may have potentially killed the bacteria, right? And you wouldn't have captured that. I also want to share with you, yes? What did you say?
2 separate sites.
2 separate sites. Very good. This is really, I think, a fascinating fact, but 1 in 3 patients who die while they're in the hospital have had sepsis. Okay? I don't know about you guys, but when I heard that statistic or read that statistic, that shook me. That is high, right? So what can we do as nurses? What do we learned about that can help prevent against sepsis? Okay, monitor. What specifically are ways that patients have been developing sepsis that we have a role in? Excellent, very good. Hygiene, potty, so catheter-acquired urinary tract infections. Why do you think that we're limited in some of the things that we can do at the hospital, right? Our urinary tract infections, our CLABSIs, our central line-associated infections, right? There's a lot of things that right now they're not letting us put in catheters, right? Foley catheters. Even limiting maybe if we're being dressing changes and things like that with central lines. So we have a lot of control, even as we're doing dressing changes on wounds and things like that. Using our sterile technique and our appropriate hygienic technique can help prevent against these patients developing sepsis. Okay, so just wanting to point that out there. All right, so this is in the shock section. Oh goodness.
You broke it.
Here we go. I have to walk around. Okay. So this, there we go. Okay. So this chart here is showing you a little bit about the role of septic shock, right, and how septic shock would develop. All right. So a few things here. So when we first have our infection, right, and then we're going to develop more of that systemic infection. I'm going to show you in a second that differentiation between actual sepsis and then that systemic inflammatory response syndrome. So that systemic inflammatory response syndrome is going to be more in that state where this becomes more widespread. It's affecting more of our organs there. And then that has the potential to develop into severe sepsis, and then as you can see at the end, that multiple organ system failure. So if we peek at this here, there we go. So this is some of the differences between sepsis, and then this is going to be more of our systemic shock, or as it progresses to get worse there. But you can see to develop actual sepsis, it's or the systemic inflammatory response system. The criteria is only 2 or more of these. So that increased temperature, okay, or heart rate, white blood cell count, respiratory rate. All right, and then more into the severe sepsis with organ failure, we're going to see become more hypotensive, that respiratory rate, and then that change in neurological status. Okay, that Glasgow Coma scale is our measurement of our neurological status. If you guys remember that back from Nursing 120, that's going to be our quick neurological assessment. All right, so when we're thinking about sepsis in general, before we even get to shock, but when we're thinking about sepsis in general, what are some of the things that we're looking at? What are some of the signs or symptoms of sepsis?
Blood pressure changes.
Blood pressure changes. Good. In what way? They tank. Very good. So we're going to see that hypotension. Very good. What else are we going to see? Tachycardia. Very good. What else are we going to see? Tachypnea. Good. What else? Okay, we can, especially as they get, so one of the things to know about sepsis, and especially as we progress into septic shock, someone was asking me, we talked about like early stages versus late stages. The later we get, the more the lack of perfusion that we get. So what your book brings up this idea that this balance between perfusion, right, and oxygenation and things like that. So as our sepsis, as our septic shock progresses, we're going to have more poor perfusion. We're going to see that manifested as things like pallor, even this change in mental status and those types of things. Those are going to be more later signs. Some of our earlier signs are going to be things like tachycardia, tachypnea, okay. Hypotension, again, is going to be more a little bit later, okay, but before even the change in mental status and things. We can even see it here, right? So we're going to see this increase. So when we're talking about, if we went back to our initial chart, that inflammatory response came before that organ failure. So in doing this assessment, what you see in this category under SIRS is what you're going to, these are the principles that you're going to see before you come here in terms of the organ failure, okay? So that increased temperature, right, the white blood cell count. One thing to know that especially in the elderly population, not all sepsis is identified or represented by having a patient who has hyperthermia. Sometimes patients may actually have a low temperature as well, and that can also support sepsis. Okay, so you just have that knowledge. All right, good. So what are some of the other lab values that we might look at for these patients? yes, we're going to look at our white blood cell count, but what else might we look at?
Well, you might do a culture.
Excellent, we're going to do our blood cultures, very good. So we're definitely going to do blood cultures. Yes, Jeff?
Might be hyperglycemic.
Excellent, very good. We can check our glucose, and we might see hyperglycemia. What else? Yes, sir. Excellent, our lactate, very good. Why are we seeing a lactate? What are we going to see regarding lactate? And why?
Is it like breakdown of
Excellent, very good. Why? What's happening?
lack of perfusion?
Very good, because we end up switching, right? With this, we're having, what ends up happening when we get a leak of capillaries and things like that, we're having a lack of perfusion, all right? And we end up switching on to an anaerobic cellular metabolism, okay? So we no longer are perfusing, so we're switching to our anaerobic. And remember, with our anaerobic, that's going to be when we're going to see that breakdown in muscle, and we have that increase in lactate or that increase in lactic acid. What's another big lab test that's more specific to sepsis?
White blood? Oh, well, no. I was going to say the differentials, like you're looking at the type of white blood cells.
C-reactive protein is a general inflammation marker, so I like your answer, but there's one more specific. What were you going to say, one, Clarissa?
I don't know if it's right, but like neutrophil levels.
So good, good idea. How about procalcitonin? Has anyone heard of that? So procalcitonin is another factor for a patient. Everyone who goes into clinical these next 2 weeks, for your last few weeks here, go and check to see if you have a patient with sepsis, if they had a procalcitonin level. You will see that is a lab value that's specific to a bacterial infection when it's elevated. So oftentimes when providers are determining sepsis, they're going to do that level. So make sure you check your patient's procalcitonin level. Okay. Very good. Excellent. So another thing that we might see is what other lab values might we see as changing in this in sepsis?
Arterial blood gases, and
Okay.
pH and things like that.
Okay, very good. What might we see in an ABG?
Metabolic acidosis.
Excellent. Metabolic acidosis. Very good. When we start, we might actually see what? In the early stages of sepsis, what might we see? Alkalosis. What type? Respiratory. So why would we see respiratory alkalosis to start? What did we just say?
Because we're getting faster.
Excellent. There's a tachypnea. But over time, right, as our organs are failing and we're getting into that anaerobic state and we're having that breakdown, right, that increase in our lactic acid and things, we're going to end up in metabolic acidosis. Good. Excellent. Other lab changes that we might see is another thing to be aware of is that when we have sepsis, we also can have a widespread of microthrombi formation. Basically, the patient can end up developing issues with coagulation, and they can develop what's called DIC, so that disseminated intravascular. You guys remember that DIC?
Mm-hmm.
Pardon?
Yeah, so they test low for platelets.
Right. Excellent. Yeah. Very good. Perfect job, Mom. So we might also see them to be, what's that called? What term could we use?
Thrombocytopenia.
Excellent job, Alana. So these patients may come out as being thrombocytopenic, okay? Thrombocytopenia, okay? Quick quiz for exam 5. When do we also talk about thrombocytopenia? What medication do we always want to check our platelet? Heparin, right? Because we talked about heparin-induced thrombocytopenia. Very good. Excellent. Okay? Good. So what's another, when we talk about sepsis, okay, what's another piece that might happen what other organ might become affected? Kidneys. Perfect. Very good. So as a result of that, what lab values might we want to monitor?
Creatinine, BUN.
BUN and creatinine. Very good. So what might we see happening with those?
It'll be
increase,
high.
Right? So increase would be poor functioning, okay? Because they're not being perfused as well, because we're having all that capillary leak and things like that, so we're not having adequate perfusion. We're not having our urinary production or our blood flow through our kidneys. So we may see an increase in our BUN and creatinine.
Are the kidneys the first to go when someone's going into organ failure? Yeah.
It's definitely one of the organs that you can see more quickly because you have that urinary output.
Urine output.
Like
okay.
So very good thinking.
Well, if you mess up the kidneys, you mess up the urine, right? So there's going to be something off about the urine.
Oh yeah. Good. Okay. One other thing here. What are some risk factors for a patient developing sepsis? Immunocompromised. Very good. What else?
Taking immunosuppressants.
Taking immunosuppressant. Very good. What else? Steroid use is a potential. Very good. What?
Infections of others.
Very good. Like what?
Like lungs or
Okay, very good. Other infections, very good. Skin, very good.
I was going to say mobility issues, maybe.
Mobility.
65 and older, right?
Excellent. Age is definitely a big one. Advancing age, very good.
What about diabetes?
Excellent.
Oh, yeah.
Excellent.
Yeah,
Very good. Diabetes is a big one, right? They have that decreased immune function. Very good. Good. What about another patient population with a disease? That would be cancer. Excellent. Very good. Cancer is a big one. Okay, good. Good. Excellent. Good. Any patient who has any type of foreign device, right? Even that patient that has chemotherapy and has, right? We talked about ports and things like that, or central lines. Okay. Good. Good. Even the very young infants are also can be predisposed to sepsis. Okay, with that organ immaturity. So in an infant, right, in a newborn or in the neonatal period, if a baby comes in and they have a temperature greater than 100.4, I believe is typically the cutoff, they will actually have to have a full sepsis workup to make sure that they don't have sepsis. They're often admitted and worked up and things like that, just because obviously they're little, they don't have the ability to even fight that infection if it were to develop.
And meningitis, isn't meningitis super common? Having babies when they have like a high fever at a really young age?
I mean, it definitely can happen. Yes, it's definitely a problem. Yes. Not super, yeah, right. I just wanted to eliminate, but yes, we could consider something like a meningitis. Good. Good. Okay. So, my PowerPoint doesn't go a lot into the specifics regarding risk factors, regarding specific clinical manifestations as I just discussed. But I want you to make sure your book does have that information within this chapter. So please make sure that you review that. Okay? All right.
Did you say clinical presentations?
Mm-hmm.
Okay.
So as we talk about this, again, one of the biggest things that we're talking about as we talk about sepsis, as we talk about septic shock, is this idea of perfusion and inadequate perfusion, definitely obviously infection, and the idea of clotting from the aspect that we just said, like DIC and things like that, and these microthrombi that form. Okay. So if we are just looking at the term of shock, well, first of all, I like this question. What type of shock is septic shock?
Distributive.
Excellent. Distributive. Why is it distributive shock? What's happening?
Everything is a problem.
Okay.
Well, it spreads, because the bacteria.
Distributed through, yeah.
Okay, very good. So it's really that widespread capillary permeability, right? That increase of that permeability, that vasodilation. We're not allowing for that. That is leading to errors in our distribution, right? That's why I think of it. So that's what is happening here. In this situation, you can see, again, this is when with oxygenation and tissue perfusion are not maintaining cell function, okay, and this abnormal cellular metabolism. All right. So here are the 4 types. Our only focus is going to be distributive, and our only focus within that is going to be sepsis, okay?
Oh, okay.
So out of that whole chapter, it should have been in the reading list as well, but our focus is sepsis and septic shock.
That'll make it easier knowing this stuff.
Okay, so when we talk about the stages of shock, though, the stages of shock are going to be similar, whatever type of shock that we're talking about here, in terms of how we assess them. Okay, so in this initial stage of shock, what does MAP stand for?
Mean arterial pressure.
Very good. How do you assess someone's MAP or MAP?
By what the Dynamap tells you.
Okay, very good. I mean, it is true.
Don't you?
It is true.
Yeah, that's what
No, it is true. It's on the monitor. We're often not performing a mathematical calculation to determine our MAP. It's typically measured by the machine that we're using.
Don't you just subtract the 2 numbers?
It's not a subtraction of the 2 numbers. It's more complicated than that.
It's over a certain amount of time.
Yeah. I don't know this full.
I think we learned it in one of our science classes.
I don't have it, but it's more than it's a difference of. It's not the same as just subtracting them. Your MCV is your. I think the pulse. What is it called? Like not the pulse pressure, but.
Yeah, it's something.
Yeah.
I know if you subtract the 2 numbers, it means something.
It does mean something, but the MAP is a bit different.
Yeah.
Now you're going to tell me if I'm wrong in a second.
No, I'm just looking up how to do it.
And your mean arterial pressure has to be above 60, right?
Correct. Very good. 65. Very good. Okay, good. So we want to keep that up because that's showing us that we're having adequate perfusion, okay? So in this initial stage, sometimes it might not be as adequate, might not be as easily to pick up on in this initial stage. We can see that it has this decreased by less than 10, okay? So what might be just a subtle thing that may happen in this stage that we may or may not pick up on? Tachypnea, very good. Tachypnea, tachycardia, right? Maybe some mild changes in that way. Okay? Okay. As we progress to the compensatory stage, we can see our MAP is going to decrease a little bit more. Okay? In this situation, our kidney compensatory systems are activated. So what am I talking about there? What's being activated? What?
The RAS system.
Excellent, very good. So our RAS system. So that's what we're talking about, like our renin and our aldosterone. All right, very good, excellent. Okay, this is where we may start seeing some hypoxia, especially some tissue hypoxia, and more of our non-vital organs. That's going to happen more in like our skin and our gastrointestinal. All right, they may start seeing some thirst. Some patients having some thirst or anxiety. Okay. And possibly here we may see some restlessness, continue with the tachycardia, tachypnea, all right, and their blood pressure may start dropping in this. They may stay in this compensation state for a bit, okay? So this would be a really important part for us to pick up on this, okay? Because if they don't pick up on this, then they're gonna move on to the progressive stage, okay? In this progressive stage, again, we're going to see more of our MAP is going to decrease even more. So now we're less than, more than 20 millimeters of mercury from our baseline. We're going to see more hypoxia into our vital organs. All right. They're going to have a more fretty kind of, they're going to become, at this point, when they're not able to compensate anymore, they're going to become bradycardic. Okay. They're still going to have that low blood pressure, but they're also going to develop, now they're not compensating. So that's when we're going to start seeing this pallor or their cool skin, all right? This is when we're going to see that decrease in urinary output, really even lack of urinary output, definitely less than that 30 milliliters per hour, potentially anuria or no urine. These patients really need really quick treatment. Like if they're not treated within the hour, there is a higher probability that they are going to end up dying from sepsis because they are going to end up in the refractory stage. Okay. So what would be some ways that we would treat our patients through this? What would be some interventions that you would want to take?
Oxygen and fluids.
Very good. Pardon? Excellent. Very good. So we can consider, especially if they're in the progressive stage, right? Now they're bradycardic, right? And they're hypotensive. We're going to consider vasopressors.
Yeah. You can say vasopressors.
Oh, perfect. Thank you. So vasopressors. And then fluids, okay, definitely. What else are these patients definitely getting?
Antibiotics.
Oxygen, antibiotics, okay, very good. Potentially these patients may even need to be intubated, especially if they progress into the refractory stage. All right, so you can see in the refractory stage, this is what's MODS stand for? Multi-organ dysfunction syndrome, very good. So we're going to have a significant issues with our major organs in this situation. Okay, these patients basically are going to go on to die. Okay, if they end up getting into this stage. All right. So it's really important that we are able to identify and intervene before that. So when we're talking about sepsis in general, there's a few ways that we can identify. So we talked about the SIRS, so we can identify as they develop into SIRS. But there's also, so this is the modified early warning syndrome, okay? And there's actually a better, I'm going to just show you this first, but this is the same thing. So this is the modified early warning system, and this is a way for us to help pick up on sepsis early. Okay, so you can see here that all the different factors. So when we look at respiratory rate, and you can see their score that they would get based on that. We look at heart rate and their score. We look at systolic blood pressure and their score. We look at their level of consciousness. We're going to talk about this a little bit more on the spring, but it's called ASPU. So where are they in their level of consciousness? all right, alert to voice, to pain, and unresponsive. And then we look at their temperature, and finally their urinary output. And you're going to see each of those are given a score, all right? So I liked this, but I liked the scoring idea better on the other chart. So based on the score that they get, then you're going to see, basically you can see like red is, the higher the score is obviously worse, okay? So if they're green, okay, yellow, orange, and red, all right? So who's going to be the one primarily monitoring this? The nurse, right? We're going to be with the one seeing this, all the time. I can tell you one example of a patient that I was taking care of in the emergency room, and it was an elderly patient, and he came in, and I forget why he even came in. He had some sort of infection, but he ended up going into he was in septic shock, but he ended up rapidly decompensating. He ended up dying in the emergency room. He was admitted, alert and awake in the emergency room, and then he was there for, it was within my shift that he came in and died, but within several hours he became rapidly hypotensive. He was tachypnic, he was tachycardic, he had a fever. He was getting his antibiotics, but he ended up decompensating so much they ended up coding and he died. I will say, honestly, that was one of my more, it doesn't sound like, it wasn't traumatic. It was traumatic in the emotional piece of how that happened, because I felt like, what could I have done differently in his care? Did I not pick up on these signs quick enough? The provider was right there. We were working together. It was a really busy day, but it was really a traumatic experience to see him go through all the stages of shock so quickly and then actually die. But anyhow, so these are things that we should be aware of. And I feel like, honestly, even in the computer, as you guys see at your facilities, we're not specifically documenting a Muse score, right? We're not going in and saying, I think my Muse score is 5 for my patients who are at risk for sepsis, right? Maybe this is something that needs to be implemented more for our patients, especially those patients who have risk factors, right? So that we are looking at this, and maybe some type of alert could be sent to the provider when that is elevated. There are specific, I know in the system that we used, the Epic system, the providers were getting alerts like consider sepsis when different lab values were elevated or vital signs and things like that. But from nursing, I think it would be interesting if we were able to utilize this and again have more, because how many people were even aware of this in existing, right? So having that awareness and being more keen in our patients developing sepsis and intercepting in that.
So definitely you'd want to be taking their vitals more often than every 4 hours.
Yes, definitely.
Yeah.
Or it's depending on how at risk the patient is, right? If I did my vitals on my patient and they were green, right? And the other thing to know is depending on the situation, especially as we look at respiratory rate and heart rate, there's other reasons that a patient can have an elevated respiratory rate and a heart rate, right? If my patient is there for even a COPD exacerbation and their respiratory rate is 28 and their heart rate is even 130, then they're already at a 5. But I'm not necessarily concerned. They're not really at risk for sepsis more than respiratory decompensation. But anyhow, I'm talking away here. So I just want you to be aware of this. This is a modified early alert warning system. It's also called the Muse score, and it's something that you could utilize. And knowing the criteria there, I'm not going to ask you to know specifically the numbers and interpreting them, but knowing that it exists, and it's something that we can use to assess patients' risk for developing sepsis. Okay. So this is just another example. There's a picture in your book as well. I just picked it. All right. So we talked about a little bit of the different stages of shock. You guys okay with that? Okay. So understanding what happens at each stage, understanding, refractory is the last stage, and those differences in our mean arterial pressure as we progress through each stage. Okay. On the bottom here, you'll see, I don't know why it's not showing up here, but there is a link if you felt like you needed. I felt like, honestly, I listened to a couple of them. There were some great sepsis videos out there that just kind of give a good overview of sepsis. There's even some from provider standpoints. I'm going to talk to you in a little bit about the sepsis bundles, and there's a lot of good videos that are discussing sepsis bundles, but they also give good background on what sepsis actually is, which was really helpful. But anyhow, so sepsis is basically going to, again, lead to this widespread capillary permeability, And as a result of that, we're going to have different chemical mediators that are able to infiltrate, and then we're going to potentially have organ failure and death. Okay? As I showed you earlier, we have systemic inflammatory response syndrome is our SIRS, and our organ dysfunction syndrome, multiple organ dysfunction syndrome, would be the END or our MODS there. Okay. All right. So we can see there is something that's called the Sepsis 3 Task Force. Okay. So you can see here they were defining sepsis. You can see this life-threatening organ dysfunction. Okay, and then again, it's the septic shock that's going to be when that we're really having this imbalance over circulatory. We have more circulatory collapse. We're not able to maintain our blood pressure. We're really seeing this progress more. We need more intervention in order to maintain our physiological processes, okay, as opposed to just sepsis alone. Okay. So again, it's this idea, whatever source it is, it's that bacteria. So this doesn't just have to be bacteria, right? This can be a bacteria, this can be a fungus, or this can be a parasite. So any of these mechanisms can cause sepsis, okay? Any of those there. There's also this other idea that we can have warm versus cold sepsis. Not another idea, but a thing. So we have warm sepsis is more of our earlier stage of sepsis, where cold sepsis is more of our late stage of sepsis. In warm sepsis, we're perfusing. Our skin is pink. We're more warm. We're more dry. In our cold sepsis, that's when we're really more lacking that perfusion, right? In warm sepsis, we're more tachycardia. In cold sepsis, we're cool. We're bradycardic. It's really more of that failure of sepsis, whereas opposed to the warm sepsis is more of that earlier sepsis. Okay. So your book just talks about that, so just do be aware of that a little bit. All right, so here we can see, I feel like these numbers, you can read these numbers, but again, the number that took home for me was the fact that 1 in 3 patients who die in a hospital die from sepsis or have sepsis. I just found that was staggering. I would never have guessed that before preparing for this. But even as you watch videos, again, a lot of these videos talking about the sepsis bundles and things like that, that was a statistic kind of really, really promoted because of how significant it is. So have that awareness. All right. As I shared with you, really the big thing here is going to be prevention, okay? Assessing someone's risk and being able to prevent them. Definitely washing our hands and asepsis through everything. All right. We know this already, but definitely removing things like IVs and catheters as soon as we can, right? We don't want these patients to have them in any longer than they can. And each time that passes while they have them in just predisposes them to more likely have an infection. So I really liked the Muse score, so I just feel like we're going to talk about, so the SOFA score, if you looked at that. We can also see the SOFA score here as well. All right, so the Muse score is just more of a modified, quicker score, and in this situation, we're going to get more details and things like that as we look at it. Honestly, to be completely honest with you, I feel like as nurses, it's more applicable for us using the Muse score. This is getting a little bit more specific in lab values and things like that. I feel like this is something I would more likely see a provider utilizing as they look at these different lab values and things, but just so you have that awareness here. All right, so you can see definitely we're seeing an alteration in our respiration, okay? Our coagulation and our platelets, all right, decreasing. Our bilirubin is going to increase, okay? Our MAP is going to decrease, all right? You can see the changes in our GCS score and then our creatinine as well. All right, so just so you have that. Okay. So we spent a little bit of time, I felt like earlier when I was talking about some risk factors and things like that, right? We've talked about age, we talked about immunocompromised conditions, we talked about chemotherapy, even getting an organ transplant, chronic kidney disease, all right? Someone said type 2 diabetes. There's a good list, okay? So to be familiar, your book has a really good chart where they kind of put a few different examples there. So just do be aware of that and know risk factors that can be associated with sepsis and septic shock. All right. So cardiovascular-wise, we described some changes that we might see there. Definitely more tachycardic in the beginning. As we progress and develop more further into like a shock state, we may see some bradycardia, worsening hypotension in those things. We've talked about the others, respiratory. We've talked about these. And then what is our minimum urinary output per hour? 30. Very good. So we're watching for that, especially as we talk about sepsis and things. As it progresses, as we said, we may see some neurological changes as well. Okay. So in terms of maybe actual changes in mental status and even becoming more restless and things. As I shared with you, two of the more specific lab values for sepsis are going to be your procalcitonin and your lactate. Okay, so those are definitely going to be two lab values that you would want to monitor. And you'd also want to monitor that white blood cell count. Also, the same with temperature. Sometimes with sepsis, a white blood cell count can be very low in addition to be very high. So you may see either, I would say I feel like having a high white blood cell count is more typical, but especially as it progresses, you may see the white blood cell count become low as well. Okay.
And as well as the drop in pulse and everything, that would begin sometime in the progressive stage.
Yeah.
Okay.
Again, I feel like more likely we typically see it that the white blood cell counts are more high, but sometimes we do see them low as well. Okay. I mentioned this idea, so widespread infection, okay, and then we talked about this idea of DIC and the organ dysfunction from the inappropriate clotting and things. And because of the inappropriate clotting and because of the decreased perfusion, because we can't maintain that intravascular volume because our capillaries, everything's leaking, that will further exacerbate our issues in poor perfusion, poor oxygenation, and those types of problems. Okay, the other thing I wanted to show you, so there's this Surviving Sepsis campaign. So this is the Surviving Sepsis campaign. This is going to show you, so over time things have changed in terms of what we do. So you can see in the first, this is talking about in 2005, what is meant by 6-hour resuscitation bundle meant all of these things needed to be done within the first 6 hours. So you can see measuring serum lactate, getting the blood cultures before antibiotics, all right, starting crystalloids and vasopressors. As we progress, what we're currently on, what's currently been recommended is the 1-hour bundle. So the 1-hour bundle doesn't mean, it just means that our goal is to have this done started within the first hour, okay? But everything there is very similar, okay? So broad spectrum antibiotics, blood cultures, the serum lactate remeasuring, and then the crystalloids at 30, and then the vasopressors. There's also been, like, if you look this up, yes, Jeff?
Sorry. So with the antibiotics, I think one of the wild questions too is like if you wait to get the blood cultures before giving the antibiotics.
Yeah.
But then something in the book said to not delay.
So you shouldn't
You
wait.
give it and then you do a culture and
Right.
then you give the drug that's actually
Treating it.
specific to that bacteria once you find out.
So you can give a broad spectrum.
Exactly. Gina said it exactly correct. So you take their blood, but you as soon as you're finished taking their blood cultures, you start a broad spectrum antibiotic. This is the same, like even if you're treated outpatient for like a UTI and get a culture, they're going to start you likely on a broad. If they're very concerned that you have a UTI, they're going to start you on an antibiotic that covers a lot of organisms, and they hope will cover what you have while they wait for your culture to return. Once the culture returns, if it shows that it is not covering what you need, then they will change the antibiotic to what you need.
So if they were to ask us what you would do first, it would be take a blood culture before even the broad spectrum antibiotic.
Exactly. You cannot give any antibiotics before you take your blood cultures because you're going to potentially destroy the blood, which would be good, but then you won't know what you need to treat.
I can see that being like a test.
Oh yeah.
Yeah.
I get it.
And I'm not being tricky if I ask a question like that.
No.
Always, you want the blood culture before you give the antibiotic. And it is the broad spectrum that would be given first. Okay. Sorry. So what I really want you to take from this is just that now it's within this 1-hour bundle, but it's the same principles. You don't need to know this specifically. These are the same principles that we've talked about the whole idea. So this idea of looking at serum lactate, so basically if the lactate is high, we want to confirm that because that's more indicative of sepsis. Getting the blood cultures before the antibiotics, the broad spectrum, maintaining that map, and then crystalloids for IV fluids. Okay, so just having the idea that these are our goals, but these are our general principles that we've talked about with sepsis. Okay? Bless you. All right. Okay, so this I'm going to kind of just leave. This would just be just basic education and management for patients who have sepsis. Basically, right, being aware of symptoms of further infection, those types of things. And then obviously our outcome is just to maintain cellular metabolism. All right, so let's look at this patient here. So 54-year-old male is 3 days following a colon resection. The nurse is delegated to the assisted personnel to obtain morning vital signs, and the temperature is 101.8. What do you guys want to do? Pardon? Assess the patient. Very good. So what do you want to assess? Okay. Good. Excellent. Very good. So we want to just do an overall assessment. What did you say, Kat? Excellent. So all we have there is just the temperature, right? So maybe you would want to know a heart rate. What else would you want to know? Respirations, blood pressure, right? Mental status, very good. What's their mental status like? Very good. I'm like thinking of even the Muse score, right? What clinical manifestations do they have that might support that they're septic? Do they have a risk factors for having sepsis? What's the risk factor? They just had surgery, right? Very good. So they just had surgery and now they have a fever. Okay, so did they have some type of introduction to an organism that caused them to have sepsis? Okay. What's going to be, after we do all these things, what's going to be another big priority for these patients? Pardon? Okay, so potentially lab. But who do we need? Tell the provider, right? So making sure that we notify the provider so they can start follow-up studies and things like that. Okay? So you guys were exactly right. So definitely completing our assessment on the client. If we need to, we can give, we didn't say this, but give the antipyretic, okay? And then definitely making sure that we contact the healthcare provider. So you guys got this head on. So good job.